Endotalks Podcast, a podcast about the latest research on endometriosis.
Hello everyone, and welcome to another episode of Endotalks Podcast. My name is Kalaitzopoulos, and it's my great pleasure to welcome Dr. Noemi Salmeri today, a physician specializing in reproductive medicine with a focus on endometriosis-associated infertility at the University of Milan in Italy. A very important center for endometriosis research with numerous publications by Professor Vercellini, Professor Somigliana, and Professor Vigano. Dr. Salmeri has worked as a visiting scientist at the National Institutes of Health in the USA and was selected as a World Endometriosis Society Early Career Ambassador in 2024. Dr. Salmeri, thank you very much for accepting our invitation and joining us today.
Hi, Dimitrios, and hello to everyone listening. And thank you so much for having me here today. I'm truly honored to be part of this podcast and have such a huge respect for the work you do with this podcast and to see this initiative raising awareness and spreading really knowledge about our common and shared passion that is endometriosis. So thank you so much again for inviting me today.
Excellent. We thank you very much. And as you maybe saw in our previous episode, Endotalks Podcast is designed for both experts and patients. With that in mind, I would like to summarize the aim of your study in a few words.
Yeah, so we do know that a lot have been said about endometriosis and IVF success, and there is a lot that has been said on the damage to the ovarian cortex after surgery for large endometriomas. And some studies have also suggested that women with endometriosis may respond less to ovarian stimulation, have lower quality eggs, reduced fertilization and embryo development, and also difficulties with implantation. And all of these are key steps of the IVF process. And for this reason, we decided to conduct this review to actually summarize the evidence and to try to make the significant points of the IVF process in women with endo. And to do that, it is important that we base our analysis and our summary of the evidence on the two best study design that should be made to tackle the problem of infertility in endo and during IVF. And these two study design that I want to underline are super important to make conclusion are comparison intra-patients, so comparing the response of each woman's affected ovary with the contralateral healthy ovary in case of unilateral endometrioma, and the matched design approach. There is a way in which we basically matched women with and without the disease on key factors like age or time of the study, medication doses, and all other what we call confounding factor that affect IVF success. So using these two main kind of study, we decided to summarize available evidence on all the IVF step in women with endometriosis.
Excellent. So let's unpack the process. Let's speak briefly about the key findings of this study.
So yes, as you said, let's unpack the process. Again, we evaluated impact on endometriosis on every step of the IVF process. And so let's go through all the steps. First, in the IVF process, there is the ovarian response to gonadotropins, that are the drugs used for ovarian stimulation. And with that, there is a large study conducted by Professor Somigliana, comparing 248 women with endo and 248 controls. And this is the largest studies on this outcome. And this study found out that the percentage of women without good quality embryos on day 3 are the same in women with and without endometriosis. So basically, endometriosis does not affect ovarian response to gonadotropin stimulation. In this chapter, we have to mention that when we look specifically at ovarian endometriomas, we have to say that for bilateral endometriomas, the outcome might be a little bit different because bilateral endometriomas may impact the number of oocytes retrieved. However, the evidence available so far suggests that the cumulative live birth rate, that is what we actually care most when we do an IVF cycle, is not affected, also in case of bilateral endometriomas. Regarding the unilateral endometriomas, we have to say that the size of endometrioma likely matters. We do not have a clear cutoff, but we know that very large endometriomas, likely over 4 centimeters, can actually distort the ovary and make the oocyte retrieval more difficult. And another aspect that we have to take in mind is that larger cysts may release over time toxic agents into the healthy ovarian tissue, and there is some evidence suggesting that could progressively damage the primordial follicular pool, but evidence so far is very scarce on this topic. And ovarian steroidogenesis and oocyte quality, that is the second step of the IVF process, is also not affected in women with endometriosis, although the evidence available is very, very, very limited. And regarding fertilization, that is the third step of the IVF process. We can say that studies comparing conventional IVF and ICSI in women with endometriosis failed to find any benefit from applying ICSI to all patients with endometriosis. Actually, in this kind of study, we have to say that comparing fertilization strategies is very hard because it is very difficult to analyze the difference, since the results are often reported per oocytes and not really per women going to the IVF process. But we know that the main indication for ICSI is the sperm is based on sperm quality. So when looking only normosospermic partners, studies that looked at actually normal sperm quality partners failed to find any benefit from using ICSI compared to conventional IVF. So fertilization in women with endometriosis is not affected. Moving on the next step of the IVF process, there is embryo quality and ploidy. So after fertilization, when the embryo is formed. So first we have to say that the gonadotropin dose and the duration of the stimulation is one of the most important factor that negatively impact the embryo quality. And with that in mind, in studies that adjusted for the same gonadotropin dose and duration of the ovarian stimulation, we found that a large meta-analysis that included actually something like 20 studies, if I remember that correctly, but there are a lot of studies for a meta-analysis, found that the number of high-quality embryos in endometriosis was similar to that in controls. So embryo quality, embryo formation, cleavage rates, high quality embryo rates are the same in women with endometriosis and controls. On the following step of the IVF process, there is implantation. That's actually the most complex aspect because some studies have suggested that women with endometriosis have an impaired endometrial receptivity, but the evidence is very scarce. We know that endometriosis could impact endometrial receptivity because of molecular change in the endometrium or eventually inflammation in the pelvic cavity due to the presence of lesions and to the disease. But there are other factors that most likely influence implantation. And especially these factors are the fact that first, when we consider women with endometriosis, they often are also poor responders. And so are women who retrieve fewer oocytes compared to controls. And poor responders are, in general, at higher risk of early progesterone elevation, which can shift the window of implantation and potentially could affect the implantation of the embryo. And the second, and to me the most important piece, is that endo can come together with adenomyosis, the sister of endometriosis. And adenomyosis is frequently associated with implantation failure due to morphological change within the uterine wall that can affect implantation of the embryo. But when focusing exclusively on women with endometriosis, we can say that when analyses that have been done focus on frozen embryo transfer, so bypassing the problem of the progesterone elevation due to poor responders, and in studies that using that evaluated the oocyte donation cycles, so oocytes donated in women with endometriosis and recipient without endometriosis, comparing the two, they had similar IVF outcomes. So all these process, the step of the IVF process are actually basically similar and comparable in women with endometriosis and controls. And we can say that endometriosis does not negatively impact the IVF success and is actually a very good indication for IVF.
Very nice. And from this whole process, what do you think? Which is the less examined? Which part of the IVF?
That's a very good question. I personally believe that, of course, the less examined so far, and the one in which we really need to work a lot on, is the implantation piece. And that's because, again, we know from studies from oocyte donation that in women with endometriosis, the implantation rate is not different from compared to recipient without endometriosis. But again, as I mentioned briefly before, the situation can be really different for women with both endometriosis and a uterine factor of infertility, especially adenomyosis. Because adenomyosis impacts the uterine peristalsis, the peristalsis, that is the uterine contractility, and the uterine wall is usually different in terms of vascularization. So it's of course a uterus that is likely less receptive to the embryo, the embryo transferred. And the problem with this, and the reason why we don't know a lot about that, is that the diagnostic criteria for non-invasive diagnosis of adenomyosis have actually only been established in recent years. The MUSA criteria, that are the ones that diagnose adenomyosis, have been made within the last decade. So before that time, adenomyosis was always, I would say, underdiagnosed or misdiagnosed with different conditions such as like fibroids. And of course, this is a huge limitation when we interpret literature, because to draw clear conclusion today is hard, considering that in the past the data were not collected assessing also adenomyosis. So we have to hope for future to provide more information on the impact of adenomyosis in endometriosis and to really unpack the process of embryo implantation in women with endometriosis.
Yes, exactly. And let me add also something. Your group brought also, in the discussion nowadays, the association between endometriosis and uterine malformations.
Absolutely.
The last paper.
Yes.
Meta-analysis.
Yes,
exactly. And this, also these factors could play a very big role in embryo implantation.
Yes. I mean, every factor that affects the uterus, we have to think at that as the recipient of the embryo. So, of course, if there is a malformation or a huge fibroid or any condition that is really, say, mentioned as uterine factor of infertility, in addition to endo, of course, that could complicate the process.
Yes, exactly. And based also on a previous publication from your group, which compared like the pregnancy and obstetrical outcome in women with endometriosis and adenomyosis. The conclusion in that paper was that the effect of adenomyosis was higher, was larger in comparison to endometriosis as far as pregnancy rate and the live birth rate. And we at that time we wrote also a letter to the editor with the title "The House and the Garden."
Yes.
What do you think about the house? Actually, about adenomyosis? Is there any strategy that we will like go through? Some authors propose like some protocols in order to downregulate adenomyosis before transfer. What do you do in your practice?
So again, that's a truly crucial point. I don't want to move the conversation from endometriosis to adenomyosis, but yes, that's really the piece that we miss now in our clinical practice. And on your question to the pregnancy outcome in patients with adenomyosis, so there are a lot of meta-analyses and large studies showing that women with adenomyosis are at higher risk of complication, especially placenta previa, preeclampsia, preterm delivery, fetal malpresentation, or postpartum hemorrhage, low birth weight, small for gestational age. And these risks are particularly concerning because they are directly linked to the fibrotic and really, again, altered uterine environment caused by adenomyosis. On the other hand, we can say that in pregnancy with endometriosis, the risks are different and probably are not as high as in women with adenomyosis. We know that in women with endometriosis, there is a higher risk of placenta previa, which appears to be independent of IVF. And other risks are actually much less pronounced. Preterm delivery can be more frequent in women with endometriosis, but it's generally after 32 weeks. So the impact of neonatal outcomes is limited. And there is a minimum risk of spontaneous hemoperitoneum in case of severe and extensive deep endometriosis, but this risk is again very rare. So it's very important when we do we manage infertile patients with endometriosis, and when we manage pregnancies in women with endometriosis, to consider the presence of concomitant adenomyosis. There is not a standard treatment on how to manage them before IVF or before embryo transfer, or in general during pregnancy, but for sure a management from referral center could be the best for these patients.
Yeah. So I think we agree that a personalized approach and also an evidence-based approach is the best treatment for women with endometriosis and/or adenomyosis.
Absolutely. I completely agree with you, and thank you for this question to highlighting this important point. But I think that it's very important to clarify a key point for everyone that is listening. That is that evidence-based medicine is not the same as personalized medicine. Because most traditional clinical trials, that we read, that we publish, that we want to read, are the primary way in which we really generate evidence-based medicine, but we want them to be controlled and designed to answer specific research questions. So they usually are, again, very well designed with a strict methodology. But the clinical practice and the real world is not always the same, because patients vary in age, medical history, lifestyle factor. I personally love the design of pragmatic clinical trial that, unlike traditional trial, are conducted in real world settings and usually include diverse patient population, have fewer restriction on treatment condition. But today, what we define as evidence-based medicine is based on standard clinical trial. So the balance between the personalized approach and evidence-based medicine is very important and essential to consider. And for women with endometriosis, we should, of course, also consider individual factor, age, surgical history especially, but also symptoms, fertility status when we manage fertility. And in general, we should try really to bridge evidence-based medicine with the concept of personalized medicine and individual variability, actually.
Absolutely agree. And it is also, we see also that 30 years ago, endometriosis research was endometriosis, yes or no. And now we're going more in detail. We know that endometriosis has lots of phenotypes. Not all endometriosis is the same.
And yes. And again, we now know how that often there is also adenomyosis or fibroids or other factors that can impact fertility as well. So it's important to consider all these individual factors.
Exactly. And it's also difficult, as you said before, it's also difficult to make all patients happy with guidelines. I mean, there should be some guidelines, but real life doesn't, it's not always like guidelines, as you said before.
Yeah. Evidence can really not fit all patients. So It's important to have standard, but personalization is important as well.
Mm-hmm. And we see usually in endometriosis associated infertility that we need a strategy. And this strategy sometimes not only one man show. The strategy usually, if we need a surgery, if we need an IVF, or if we need another kind of treatment, it should be like sometimes more than one physicians. And that's why I would like to ask you, what do you think about the multidisciplinary approach and the multidisciplinary boards of endometriosis?
Of course, you gave already the answer, because it is the answer. A multidisciplinary approach is extremely valuable in the diagnosis, in the management, in the follow-up of patients with endometriosis in general, both suffering from infertility and especially for pain. It's important to know and follow patients with endometriosis and start this multidisciplinary management early, based on symptom, on clinical presentation, and include gynecologists, fertility specialists, radiologists, pain specialists, neurologists, and really improving not only the fertility outcomes or the pain outcomes, but really the overall quality of life of patients with endometriosis.
Absolutely. Because, as you maybe you have seen already, the strategy could be the same, but with the others, if the steps are in another direction, then we can have like a totally different outcome.
Absolutely, yes.
Super. And I think I'm very happy with our discussion today. Thank you very much, Noemi.
Thank you.
I'd like to underline one more time the finding of your study for our listeners. Could you summarize the conclusion of your study?
So the conclusion of the study is that endometriosis is a great indication to IVF, that there is no reason to believe that endometriosis can alter any step of the IVF process. And actually, I want to add something very, very small. That is that when we look really at the natural history of endometriosis, we need to consider that, as Professor Somigliana recently mentioned in one of his work, he said that 20% of women with endometriosis will never attempt pregnancy. 40% of women will conceive spontaneously without the need to do anything. 25% will need IVF and will achieve pregnancy successfully, and only 15% at the end will reach IVF too late and will need to require like second line strategies such as donation or oocyte donation or heterologous fertilization. But most of these patients will be able to conceive. So that's a very important message, I believe, for our patients listening, that having endo doesn't mean being infertile forever.
Very interesting. I think this is a very important point of for this episode of Endotalks Podcast. I would like one more time to thank you again for your time and for a great discussion. And that was another Endotalk podcast episode. See you next one.
Thank you. Bye.
Endotalks Podcast, a podcast about the latest research on endometriosis.